All right, so hey everyone. Today we're really excited to hear from Dr. Tamika Odum. Dr. Odum is an associate professor of sociology at the University of Cincinnati. She began her career in higher education administration, where she served as the director of a university women's center. After completing her PhD in sociology at UC, she decided to change careers to focus on teaching and scholarship. Dr. Odum is a qualitative researcher with expertise in community-based participatory research. Her research focuses on abortion access, contraception, motherhood, and communities of color. Throughout her career, Dr. Odum has built strong connections to the community by serving on local community boards, church affiliations, and working with women's advocacy groups in the city of Cincinnati. So thank you so much for joining us this evening, Dr. Odum, and I'll let you take it away.
Thank you so much, Nora. I'm going to go ahead and share my screen. All right, am I good to go? Let's see. There we go. All right, well, thank you so much. So when I teach, I actually make my students turn on their video so we can sort of simulate the online environment. I am not going to do that here, but because I have my screen showing, I actually can't see all the blank screens. But I hope that when we get to the end of the session that you all would be open and willing to turn your videos on. Not mandatory, but I always like to put names with faces, and it provides a little bit more of a connection for us as we learn together and learn from each other. So thank you again for having me. I am a sociologist, as Nora mentioned. And I actually, one of my area of expertise is the medical sociology, or the sociology of health and illness. And so I look at sociology and health and really focus on sort of those social determinants of health, and recognizing that health is more than a physiological manifestation of the body, but it is really an all-encompassing way and state of being that actually just affects so many parts of our life. So let me tell you what we'll do today. So here are the learning objectives that I hope to accomplish by the end of our time. Please feel free, if you have a question, to post it in the chat. I am also not opposed to you all unmuting yourself and asking a question. It does not throw me off. I really am, you know, as much as I'd like this to be more of a discussion, it's structured very in a sense where it's structured, but I really do want this to have some dialogue. So feel free to jump in when you can. I do have it structured where I'll talk for maybe the first 30 minutes or so, and then leave some time for us to discuss at the end. But if you are so inclined and want to jump in there before we get to that point, feel free to do that. So we'll talk a little bit about what we call the social determinants of health, and that helps us understand how someone's race, nationality, and economic status affects their overall health. I'm going to talk about that in its general sense, and then later on, as we get through some of the content, then we'll talk more about COVID-19 and its implications, and how social determinants of health actually are affecting the incidence and outcomes of COVID-19. We'll look a little bit more about how COVID is sort of deepening pre-existing social inequalities that are there, and really sort of examine some of the consequences that are related not just to sort of the health outcome in general, or the direct health outcome of COVID, but also like what are the implications of the pandemic largely in terms of the lockdown. You all had an article to read today and a podcast. I really love the Behind the White Coat podcast. There are lots and lots of great information that's learned there, but just some really riveting dialogue that helps us to think beyond the now, but also this theme of sort of collective action, which as a scholar, I call myself and consider myself a scholar activist. So not just sitting at the screen and telling you everything that's wrong with the world and here are all of the data and the numbers, but really what can we do about it? So I hope we'll talk a little bit more about that at the end, and that is the third learning objective that we'll cover today, and that is thinking about as healthcare providers in a healthcare community, how can we address some of those health disparities and then build trust within the community. And that's what we'll do. I do have 2 videos that I will show. Hopefully WebEx will be our friend today and we won't have too much lag and we'll be able to do that. When I teach, I am a storyteller. I love telling stories. Since I only have an hour, I'm not going to tell my own story because the next thing you know, we'll be here 2 hours in. So I have a little bit more structured stories, both of positive, although it does talk about some of the consequences and negatives of understanding inequalities in health. It does have leads us with a sense of hope and a sense of we can get through this. And so I want to make sure that we start with a story and also end with a story. All right, so let's start off with talking about the social determinants of health. So as I mentioned before, so health is just not this physiological manifestation of disease in our body. Health is more holistic when we're thinking about wellness and health outcomes. In order to address health disparities, though, we need to understand why they exist. And the why part is where the social determinants of health come in. And so when you're thinking about health from the social aspect, you recognize that the social determinants of health really do affect a person's health outcome. So where you live matters. If you have access to healthcare, that matters. Your educational status, that matters. Whether or not you live in poverty or you're more affluent, all of that matters. Thinking about the social, psychological aspects of your being, that matters. So we're talking about racism, we're talking about sexism, we're talking about our instances of gender-based violence. Like all of these things provide a social and a community context that affects our overall health outcome. And so when you're thinking about this in terms of the COVID-19 pandemic, it's always important for us to make sure that we are coming at it not just from the science of here is what's happening in our community. And I'll talk about this in a little bit where when this first came out, there was this rhetoric that said that COVID-19 doesn't discriminate against people. No one is exempt. And the reality is the numbers actually just don't say that. It actually does say that COVID-19 is disproportionately affecting certain groups of people. And so in order to help us understand why that's happening, we really have to get to the bottom of understanding the fullness of what it means to have a positive health outcome. And we do that by understanding the social determinants of health. So we're going to start with Michelle's story. And Michelle's story is a good one. It's a story of hope, but it's also a story of reality, of when we are talking about this social determinants of health, what are we talking about? When I say where you live matters, people often talk about when we're looking at rates and incidents of morbidity and mortality of COVID-19, we know that people who have heart disease, people who are obese, people who have high blood pressure, they are more likely to die and have negative health outcomes than people who do not have those types of diseases. But we'll talk about this later on. This idea of race is actually not a real one. Race is a social construct. So when you're talking about race as what it is, it's actually not, there's no one genetic marker that you can find in all of one race and none of another race. So this is society's way to group certain people. We'll talk a little bit more about racism and its effects, but that actually matters. So although race isn't real, race matters in our society, and it matters in ways that we might not have thought of before. So if you live in a community that doesn't have access to grocery stores, and you have to catch 3 and 4 and 5 buses to get to a grocery store, you're more likely to go to the corner store that has limited access to healthy foods, healthy fruits, healthy vegetables. This actually affects your ability to stay healthy. So if you don't have access to healthy foods, you can't stay healthy. If you have grown up in a culture where the practice is for you to come together on Sundays and you eat foods that provide different levels of cultural significance to you that may or may not be healthy, it's hard to break that cultural tradition. And so that actually affects your health outcome. So take a couple minutes and listen to Michelle's story.
The world has got to change. I lived in a community that was so prosperous with doctors and lawyers and politicians. Now we have drug dealers in corner stores that they don't sell anything but the wrong things. You cannot deny the impact that it has on people's health. I have been in West Baltimore my entire life. As far as money, my mother didn't have any money. I don't want to say she was poor, I'll say low income. Poor we were, though. In the 50s, we didn't have many choices as far as healthcare. The healthcare system then was limited. It was not good for us. And medicine costing so much that my family says sometimes, will I eat or will I pay for my medicine?
Which one do you, Mommy?
Oh, I just love my daughters when they come over and we get together and we cook and prepare meals together. It's healthy meals. When my oldest went to college, she came back with a different diet.
Now what happens is if I do a meatloaf, it's turkey instead of ground beef. You know, I make spaghetti, I make chili, stuff like that. It's with turkey and chicken. We grew up, we ate pork. We ate bacon, we ate a fresh shoulder, we ate pork chops. I did not think it was not healthy eating, right? Because this is what we were accustomed to. I was in denial. I didn't want to face the fact that I was becoming a diabetic.
The impact is the fact that my family ended up with heart disease, emphysema, diabetes, cancer. My mother's sister, her daughter died of diabetes. She was an amputee. My mother died of a massive heart attack. And
to address health disparities, we need to understand why they exist, that they're not due to one single factor. They're the result of policy decisions we make as a society. They're due to the environment, health education, insurance and access to care, access to healthy food, and stress. Those stresses are actually experienced disproportionately by people who are poor and people who have been historically disadvantaged in this society.
Solutions to these problems cannot just be medical. It's systemic. And that means everybody has to get involved.
If we want a nation to be strong, the people in that nation have to be healthy. They have to be well. If there's anything that we can do to stamp out disparities, we need to do it by any means necessary.
Hi, Ms. Simmons. Here at East Baltimore Medical Center, most of the patients are underserved. We need nice deep breaths coming up through your mouth. Michelle is a terrific success story. There was actually a year where she had lost her job, and before she found a new one, she had no health insurance. And she still managed to buy her medicines out of pocket, paid out of pocket to come and have doctor visits. She was really invested in her own health.
The next thing on the agenda is the community update. So I'm going to
Michelle joined our community advisory board in 2011. We provide education to the community about health and about research. We offer training programs for community health workers. We can be sure that we are meeting the needs of people appropriately and that we're not leaving out certain groups of people that have traditionally not been included in conversations related to health and healthcare. Our strong relationship with the community is just essential. There's no way that we could do what we're doing without their input. And my work is just one of many initiatives here at Hopkins.
Ms. Simmons is a great example of what happens when we get it right as clinicians and as an institution.
I am a fighter. I am a believer. I stand for what's right. And what's right is people's health. And I will never give up as long as I have breath in my body.
One of the things that is so important is that people have what I call a liberated future. And it's hard to be liberated when you're not healthy. When I say liberated, I mean freedom to be all that God meant for you to be. When we don't deal with disparities, then what we're doing is denying people an opportunity to give back to the world. So we've got to fight it. We've got to fight it with everything we've got.
All right, so I love Michelle's story because it gives a hard truth of what's happening in our communities, but it gives a ray of hope in terms of we being able to collectively come together to make sure that health equity is available for all that are in the community. And so I want to now dive into social inequalities in the history of pandemics. And so many people are actually, it's funny as I listen to folks and many of them are students and they say, you know, well, this has never happened before. And this is new. And for many of us, it is new because we've never experienced a pandemic before, a global pandemic before. Like we've never been here. However, we actually have been here before. We might not have experienced it ourselves, but we have experienced pandemics before. And even then, you could see that there were some inequalities that were inherent in the health outcomes of people who were dealing with other pandemics. So the Spanish flu of 1931, even then, scientists were looking at that there were some clear inequalities by social class. So social economic class actually mattered. And so they were seeing a significantly high incidence of Spanish flu in people who were working class, which was, again, we're seeing some of those very same things when we're dealing with COVID-19 today, is that we are seeing that the disproportionate number of people who are working class are affected by COVID-19. And so this actually challenged this widely held belief that, you know, the flu hit the rich and the poor alike. And the reality is it actually did not hit the rich and the poor alike. And we saw that then, and we are seeing it now. So it's actually not surprised that we're seeing these disparities within health. So thinking about H1N1, and so many people say like, oh my gosh, this is the first time that we've experienced this, but the reality is actually H1N1 was not too long ago, and it too was a matter of let's figure out who this is affecting, and people with financial issues. We're talking about people who had barriers to healthcare, people who were in poverty, actually were also disproportionately affected by H1N1. And then we get to COVID-19 and again, that claim of we're all in this together was a fallacy that continued to be shared, right? That this was something that uniquely affected everyone. But the reality was it actually was not uniquely affected by everyone. It did discriminate against certain populations. So when you're looking at the rates, and I know that you all have a health talk in a couple of weeks on public health, so I will spend less time talking about the data of things. But the important thing is 6 or 7, like COVID-19 infection is 6 or 7 times higher in the most deprived areas. So people who are in poverty, we are seeing a significantly higher rate, almost 6 to 7 times higher of people who have COVID-19 infection. So what does that mean? It's not hitting us all the same. There are some other things that are going on that can help understand the manifestation of this disease. Okay, so the annotated tool. All right, there we go. All right, so let's talk a little bit about this concept of syndemic pandemic. And what the concept of syndemic pandemic is really talking about how we have these co-occurring synergenic pandemics, right? And really, it's talking about how one interacts and exaggerates some already pre-existing conditions. So we're talking about non-communicable diseases like obesity and diabetes and health disease, heart disease, high blood pressures, and other social conditions. So these things are co-occurring. So when the COVID pandemic hit, although we had this history of understanding that, you know what, these types of things affect different groups of people very differently, what COVID did was really draw light on these synergenic occurrences of disease. So we're thinking about, like, take for example, you've got disadvantaged neighborhoods and ethnic minorities. We are seeing just the clinical risk factors are increasing. The severity of mortality, depending upon where you live, depending upon whether you're in poverty, depending upon what underlying condition that you have. And remember, when we talked about those social determinants of health, minority groups are actually at a higher risk of having heart disease, liver disease, cancer, cardiovascular things. And that is in part not just because there's something physiologically that's unique to this particular population, but it's the social determinants of health that are really affecting this particular group's health outcome. So when we're thinking about sort of how the outbreak continues or contributes to inequality, it's really important for us to recognize is that it is deepening inequalities in the most marginalized communities. So when we're talking about deepening inequalities, and we'll talk about this a little bit later in more detail, but you're talking about the deepening of the inequalities where you have the COVID pandemic that hits, right? And then you have people who are already in poverty, which means they're most likely in hourly jobs. And if they don't have access to healthcare and they are then exposed to COVID-19, which means they have to take off work, which means if they don't work, they don't get paid. And if they don't get paid, then they don't eat. And so that's another example of how the syndemic pandemic and the co-occurring of inequalities that the pandemic has brought us really deepens the structure of inequality that people have to be faced with, because then it becomes more than just about the manifestation of the disease, but really how the disease is affecting life overall. So let's talk a little bit about, and I'm going to give you two examples of how social determinants of health manifest themselves within the COVID pandemic. So the first one is housing, right? And so we talked about where you live matters. And I wanted to talk a little bit more about what does that mean as it relates to COVID. So when you're thinking about neighborhoods that are economically impoverished and they're more likely to contain houses that have duplexes, right? They're more likely to contain complexes that are smaller facilities. And when people are struggling to pay bills, what happens is that they then move together. So you've got these smaller, greener spaces, or you've got these smaller spaces, but you've got more people that are in that space, which makes the likelihood of transmitting the disease even higher just by the sheer fact of where they live. And so it's important to recognize that urban environments actually have a much, much higher rate. I remember this summer, I live by UC and I'm by UC main campus, and I live over in the Mount Auburn area, and it had one of the highest incidents of COVID. And we were on one of those higher lists. And as I walk through my neighborhood, really, there's tons of buildings where it's lots of apartments, the houses are very close together. I can almost reach out and touch my neighbor. And these are all things that actually contribute to the increased likelihood of spread of the disease. Thinking about the psychosocial aspect of it is also important. So I talked a little bit early, and I just sort of hinted at this idea around race and racism, but recognizing that the psychosocial manifestation of dealing with discrimination and dealing with racism and sexism and all of these things actually have an adverse effect on our overall health. So when you are stressed, you are likely to have more cortisol buildup. And when your body has cortisol that is in excess, it makes your body not able to do the things that they need to do. And that is actually in direct relation to the stressors that are there. So someone who is dealing with workplace discrimination is going to have to deal with a level of stress that someone who doesn't have to deal with that is. Someone who is trying to manage a system where they're dealing with unemployment. The psychosocial stressors that are happening there greatly affect the health outcomes that they will experience. So when you're talking about sort of the deepening of the pre-existing conditions that are inherent within the pandemic that we're currently experiencing, one important thing, and I think is a good point of connection for us, is to understand the lockdown. So when this all hit, we were in a space where, you know what, everyone needed to shut down. And for many people, I know I heard lots of rhetoric in my communities, well, we're just going to stay home and it's going to be all good. And for people who work at home, well, yeah, it didn't affect you in the same ways. But what about the people who actually didn't have a choice to stay home? The work from home option was not for them. And so they had to be out. Not only were these jobs high stress level jobs that they had to come in contact more and more with people that could possibly transmit the virus, but the stress of them actually being in that job and worrying about bringing something back to their family, there was a mental health issue that was there. Thinking about those people who had to stay home and were able to stay home, we saw increases in gender-based violence. And so these are all sorts of things that, although they have always been present, the pandemic really shed light and really brought it more attention that we have some structural systemic issues that have been exposed, all due to the occurrences of COVID-19. So I would be remiss without talking about racism and health. And, you know, I talked earlier about race being this idea, like race is not real. And so when you're thinking about this idea of racism, although race is not real, race matters. And we have racism in terms of the system. And this system is a system of structuring opportunities. And we assign value based on how someone looks. That is the color of their skin. And so when we're thinking about our overall health, we recognize that racism actually is the root cause. So we can't talk about social determinants of health. We can't talk about the full holistic manifestation of health without talking about racism. So racism hurts the health of our nation. And so that's why public health entities have then identified that public health is a crisis, or that racism is a public health crisis. And so while if we're preventing opportunities for people to attain the highest level of health, and that's what racism does. And so we want to make sure that we recognize that racism is the driving force of social determinants of health. So as we're talking about housing, we're talking about education, we're talking about employment, we're talking about access to healthcare, we have to recognize that racism actually is at the heart of talking about all of those things. And so we can't talk about those as social determinants of health without talking about racism as a barrier to health equity. So what I want to do now is I want us to spend some time, and I want you to I'm going to pose a question to you. I have a short closing video that I would like to show you, and it's 7 minutes long, but we may not watch the entire thing. But as we're watching it, I want you to be thinking about this question: how can the medical community work together to acknowledge and address inequalities in access to care and health outcomes? And so I want us to end on a positive note, but thinking about what can we do as a community. As someone who does community-based research and looks at COVID, particularly as it relates to access to reproductive health, I have found more and more in my research that it is so very important that we recognize that this has to be a collective effort. This is not something that can be solved by physicians alone or health administrators alone, that this has to be a collective effort that involves the community at large. So I want you to think about that question. I'm going to show a little bit of the short clip that will take us out, and then we will have a conversation.
I had one shift where I saw about 84 patients.
The first 21 days, we had to work consecutively without an off day. These are 12, 13-hour shifts.
I did 7 days in a row of 12-hour shifts in the ICU. That's all COVID patients. That's definitely a huge shift from my usual world of gastroenterology.
So I was the first faculty doing that COVID week. All of our patients ended up being COVID-19 positive. Some of those patients ended up, passing away, unfortunately, but we had to keep on moving.
I've been working as a primary care doctor over the last 4 years now. This is certainly the wildest thing any of us has seen.
Typically, we see very diverse racially and socioeconomically patient population. And it was interesting because I mentioned to our staff a few weeks ago, I said, do you notice that more of our patients coming in, they look like us? And everyone said, oh, absolutely.
Historically, African Americans and other minorities such as Hispanics have disproportionate numbers of hypertension, diabetes, high cholesterol. These things are hard and challenging to manage on their own. They also weaken the immune system, weaken the ability to heal.
Unfortunately, those diseases tend to track with structural and systemic factors around the country, and those include lower income, lower rates of employment, lower rates of access to insurance.
When you put like a crisis on top of a crisis, these communities are going to do the most poorly.
The patients that I noticed that didn't do too well, they were actually the patients who were obese, who had a BMI, a body mass index greater than 30, 35. Those were the patients that we saw who needed the ventilators, they needed machines.
WebEx never fails us.
It's happening more often,
And of course,
and it's not surprising. People are seeking out new places, trying new things, and discovering the best part is often hidden in the journey along the way. Find yourself in the Mazda CX-30. Want more power for your pursuit? Introducing the Mazda CX-30 Turbo with all-wheel drive.
I had one shift where I saw about 84 patients.
As a primary
The patients that I noticed that didn't do too well, they were actually the patients who were obese, who had a BMI, a body mass index greater than 30, 35. Those were the patients that we saw who needed the ventilator, they needed machines to help them breathe.
Diabetes is unfortunately 60% more common in African Americans than in our white counterparts. The risk of diabetes is higher due to issues around diet, due to issues around treatment of other chronic conditions that worsen diabetes, such as obesity.
Really getting through to people of color, especially elders, in regard to their diet is definitely challenging. They grew up eating the scraps of food, the portions of food high in salt and high in fat.
I know from growing up in Detroit in a low-income family that when you have to feed your family, buying fresh fruits and vegetables is not necessarily affordable. And so if you're turning to these calorie-dense foods, you'll get your family fed. Unfortunately, what comes with that, though, is obesity and diabetes and high blood pressure.
Food deserts really influence the way people eat. If you don't have access to the green vegetables, to the healthy fruits, unfortunately, you're going to be more likely to buy the chips, the soda, the processed foods that increase one's rates of diabetes.
We started seeing more Black and Brown patients over the last few weeks, and some of them were essential workers. They didn't have the luxury of working from home, and we saw less white patients or patients that could work remotely from home. It was, as I said, incredibly striking.
Right now, we know that there are still states, for example, that did not expand Medicaid to be able to ensure that the lowest income Americans, who unfortunately in our society tend to be from Black and Brown backgrounds, have access to insurance. We know there are about 27 million uninsured in the country right now, and a much higher proportion of those individuals are Black and Hispanic.
We've had a number of patients come into our urgent care at the front desk and asking if, how much they will have to pay, how much do they have for the visit, how much do they have to pay if they were to get testing. So these are real concerns and absolutely a barrier, especially for people who are undocumented and who don't have insurance.
Many people don't know how to advocate their health because maybe they've not had the resources or they're not comfortable going to the doctor. So yes, you see that they'll show up when things are so bad, or they're knocking, on death's door, for lack of better words.
Workforce diversity, we know, is one of the solutions to addressing racial healthcare disparities. And the fact is that, especially among physicians and nurses and other healthcare professionals, our numbers are quite low when you compare our numbers in the US population.
So if you were to ask me, overall, is it diverse here in terms of the physician population? I'd say to a degree, in terms of diverse, in terms of a large number of underrepresented minorities.
All right, so I cut it off just at the last because I want to give us enough time to have some conversation and some dialogue about some of the things that we learned. I want you to use this space. I posed a question about how can the medical community work together to acknowledge and address inequalities in access to care and health outcomes. But I know that I also sent you all a podcast to listen to, and you all had some great reflections that were there. So I encourage you to use this time to either jot down some comments or questions, respond to the question that I posed, or you can ask me questions and then we can just get a dialogue started. So I'm going to turn it over to you all to close this out. All right, so let's see. As a healthcare worker spending years in the field, specifically working with underserved populations, how do you deal with activism burnout? Yes, especially when you are trying to help so many people experiencing hardships, obstacles in a short amount of time. So yeah, I think that's a great question. And, you know, I have this conversation with sort of my other scholar activist folks, and my advice is always to remember that we're caring for other people, but we cannot pour from an empty cup. So we have to care for ourselves. And so that burnout is real, but recognizing that sometimes we have to take a break from it is an important step. Sometimes we think that we have to go, but we are running on fumes, and the psychosocial determinants that we talk about that sort of cause a increase in our body's ability to ward off disease then becomes the same thing that we are dealing with ourselves, because we haven't done the work to make sure that we care for ourselves. And so I think that burnout is real, and the important thing is to take a step back, put ourselves in the center, and take care of us. The one thing I think that's interesting when you think about that is often we think that if we're not doing the work, then the work is not going to get done. But when you have a community sort of lens to tackling this issue, then you recognize that actually, if you don't do the work, other people are also doing the work. And if we do this as a community, that means that someone else can carry the weight while you take a breather and you take a breath. And so it's important to take care of ourselves so that we can take care for others. So have the increase in realization of these disparities during the pandemic caused there to be any, hold on, my screen is moving, any systemic change in how healthcare providers treat patients? So yeah, and this I think is what gives me hope, is that you are seeing some more focused effort in making sure that we have diverse populations that are actually have the opportunity to go in the field of medicine, and you're seeing some changes there. I always worry about when you see all these trainings pop up and people think that that's actually the way to solve the problem is just let's throw some trainings in so that we'll know better, so we'll do better. And in some senses, I think that works. But the reality is that we really want that systemic change. So, you know, in that last short clip, we saw that really only 5% of the medical field are African American. And that's a small number, particularly when you've got lots and lots of folks that are coming in to be treated. And if they are in a space where they feel more comfortable with someone who looks like themselves, then how do we manage that? And so another question that oftentimes follows that is that, well, if I don't look like a patient, how can I gain that patient's trust? And I think just the reality of acknowledging that this is a systemic issue, I think is important. And patients understanding that you know that is also part of the problem or part of the solution as well. So you are seeing some increases in terms of schools that are doing more specific outreach. Look at Cincinnati, they have I believe it's Cincinnati Pride, where they are directly targeting Cincinnati public schools, which oftentimes have large proportions of students who are students of color and economically impoverished, and they're making sure that they have the opportunity to come into health. You have initiatives such as in the STEM disciplines that are doing things to raise more awareness. As before, lots of students sort of jumped on. We were talking a little bit about the change in the MCAT and requiring the social science component of the NCAT, which was really like, you know what, we recognize as a medical community that this is important. And we want to train our future physicians to recognize this more holistic approach to health. So I do see some changes that are there. So how do we prepare for the next pandemic in order to reduce these disparities? Can the government add policy to establish an emergency fund for underprivileged areas? So that's an interesting question, and it's a good question. So I like that because you're thinking about like, so what do we do? Because we know that we're going to have another pandemic. Like, it's not like this is not the first pandemic that we've been through, and it actually won't be the last. As much as I wish that it would be the last, it's not going to be. So that idea about, so what can we do more structurally? And I like the question about what can we do as a government? How can we shape policy? And policy is actually super important in making sure that these infrastructures are in place to support communities of color. And so, eventually I think that it will serve likely as sort of one step to it. So what does that require to do? It requires people with knowledge to fight to elect people who recognize this. And when you fight to elect people who recognize the importance of the social determinants, when you recognize the importance of understanding health disparities more holistically, then you are going to have people that are pushing policies that will support those people who are more likely to be disadvantaged. And so that you're on it. Like, how can we do it? I'm not sure how we can do it outside of electing officials that are supportive of it, but I think that will be huge. We have to change voting in ways that we haven't done before, and making sure that that's center and core of whatever platform is there. Let's see. Next one, I think so as you mentioned, this is not the first time we've seen inequality related to a pandemic. How do you think we can ensure that we have learned from this pandemic, causes sustainable impact for change? Yeah, so how can we learn for this? So what I think is important, and this is what I like to tell many of my students, is that we have to have education. So how can we learn? Is we can learn by talking. So when constantly when I'm in conversations with people about, oh my God, this is the first pandemic we've ever been in before, the conversation needs to be started that says, well, not so much. And so although we may think like that's small, like it seems like a small impact, like me just having a conversation with someone, letting them know that, hey, so we've actually been here before, and here are the things that happened this time. Here are the things that we can do different. That actually makes a huge difference in how we move, because that one person will then go tell another person, and then go tell another person, and then go tell another person. So I think that that's one area and aspect where we can sort of make a difference in terms of making change. How can we learn? Again, it goes back to elective officials. And so we mentioned, or actually I might have forgotten to mention this, but when we're talking about sort of the consequences of the syndemic pandemic and what are the more larger societal consequences, but it has political implications. As much as we'd like to think that this is devoid of any sort of political action, like it actually does relate to that. And so the people who are in power are the people who are shaping the narrative. And so we have to put people in power who know how to shape the realness of that narrative. And so that, I think, is extremely, extremely important. And it is critical for sustaining a society that provides health equity to all people that live here. And it's one of those things that it will take a while. So this is not something that will happen overnight. This is not something that in, another 50 years, if we are have another pandemic that's here that will then be like, we learned and we're all good. We may be able to do things a little bit differently, and hopefully that we will continue on the course. I think the both positive and negative thing of the COVID-19. So I don't know if you remember, but H1N1, it kind of felt like it came and it went. Like it wasn't like this whole, like I remember it and then it wasn't there. COVID is here, and COVID will be here for a while. And it's one of those things that's in your face that forces you not to forget it. And so this is a conversation that we have to continue to have and continue to make changes. And COVID is actually forcing us to do that because it's not going away. It's not going away anytime soon. Thankfully, with vaccines that are coming out, we can get some relief in the near future, but it's right there. It's right there. And it's there to remind us that we have lots and lots of work to do. So the US spends billions of dollars on healthcare, but why do we think it's so difficult to create a healthcare system where underserved and underprivileged communities are able to have insurance that covers sufficient physical and mental health services? So that is a really, really good question. And sorry, my plan was not to answer all of these questions, just me. So if anyone else would like to jump in with thoughts or additions, please, please, please feel free to do so. But I will tackle this a little bit. So what we have to understand when we're thinking about amount of money and sort of the healthcare system, you have to recognize that the healthcare system was actually built on inequality. So it wasn't like the foundation was great from the beginning. And so like when we're thinking about like, why is it okay to have, like, why is it so difficult? It's so difficult because the foundation of the healthcare system is actually built on inequality. And so one of my radical views of thinking is that we have to tear the whole system down. And the reality is that's probably not realistic in this point in time, but eventually we have to start getting at the root core and cause of what's going on. And that's the foundation of some of these institutions, and particularly the medical establishment that we have built. I mean, we are still feeling the effects of past mistreatment, from Henrietta Lacks to the Tuskegee experiment to all sorts of things that disproportionately looked at humans who were deemed as not human, were deemed as something other than. And this was the foundation of our medical establishment. And so in order to really sort of shift the thinking and the money, we've really got to recognize that this is a foundational issue. It's a systemic issue, and we can't keep putting Band-Aids on it. So we can't just say, well, we're going to have a training, or we're going to send a bus to pick up all the people of color and bring them to the doctor. So while some of that is actually important and it matters to health access, you have to recognize that the story is larger than that. And if we continue to do that at the surface level and we don't really get at the foundation of why we're here in the first place, then we won't see any sort of effective change in the future. So what's your opinion of Ohio's approach to the COVID-19 vaccine distribution and how you would improve it so that it better reflects the social inequalities that many Ohioans are experiencing? So I can go on and on actually about this topic, and it's really difficult. And I'll share a story of sort of my mother, who is 76 years old and has struggled to get a COVID vaccine. And so when you look at her situation, you know, I am someone who, although my mother is in Cleveland, Ohio, and I am in Cincinnati, Ohio, I have access to a computer. I also have access to a phone. I also have access to knowledge where I can pick up the phone. I can get her an appointment. I was up to 1 o'clock in the morning refreshing my screen to see if I can get her in. Eventually, after about 3.5 weeks of trying, I was able to get her into an appointment. And if you think about that in terms of people who don't have advocates with them, so people who are not in nursing homes, who don't have a structure that allows them access to that and will take care of that for them. You have people who don't have family who can get on the internet. I mean, most ways to get COVID vaccines require you to have the internet and require you to have a computer. If someone is not technology based and is not savvy, then they're going to struggle. If they can't get the information, then they're going to struggle. Like if they can't have access to a space that's right around the corner, then they are going to have trouble. So all of these things are just really super important. So like, what could they have done different? I'm not sure what they could have done different, but I know that what they have done already, that it definitely disproportionately advantages certain groups of people, those people who have advocates that can help them, those people who have access to internet. And those people who don't have access to internet are typically people who are brown and Black and people who are poor and don't have access to these things. And so there's an issue. And so we have to figure out ways, whether I go back to that, there's a truck that goes from neighborhood to neighborhood that makes sure that they are calling people or that they are driving by so that people can get vaccines. All of that really matters. And so the approach definitely is not great. And they should have thought it through a little bit more, but I think that we can learn from how this rollout went. The other thing is there are some communities that actually have gotten it right, where people are not waiting weeks and weeks and weeks to get a COVID vaccine, that they were able to schedule an appointment. They were able to pick up the phone and call someone, and that person schedule the appointment for them. And so I think that we can take some cues from some of the smaller communities that were able to roll their vaccine out a little bit more with ease than those people who were having a little bit more trouble. Well, if there's nothing else, I think that is all that I have. Please feel free to reach out. I'm right here on campus, so you can, it's odomtc at mail.uc.edu. If you don't remember that, which I actually most of the time don't remember what the last part is, you can just search me up by email. I'm actually in the process of creating a course on social determinants of health and medical sociology, and looking at some health disparities as it relates to sort of society. And so look for that if you're looking for general ed. I'm hoping to have it up and running by next spring. So maybe I will see you all there soon.